These are a relatively new class of drugs. They inhibit the ability or interfere with the ability of the virus to integrate into the host cell. So if it can't do that, then it's going to not be able to replicate. So that's its job. Has good activity against HIV 1 and 2. It's one of the preferred agents for treatment-naive patients in combination with the 2 NRTIs. They also are, you might at least underline, they are good for patients at higher risk for cardiovascular disease and have abnormal lipid profiles or multiple risk factors for coronary artery disease. There are 3 in this class. They're very well tolerated, have very few side effects. 2 of them have a low resistance to, or barrier to resistance. And one of them is, the newer one is a little bit better. So Raltegravir, well tolerated, but is very vulnerable to the development of mutations in the virus and then resistance. Elbetagravir is also in that category. It requires a booster, so either ritonavir or cobicistat. The last one and the newer one is the dolutegravir, and it is used in people who are likely to develop a resistant bug or virus. So, and it is, to kind of keep it separate, more drug interactions with that one, and they're listed there for you, more CNS side effects compared to the others. Next page, protease inhibitors, old class of drugs. We used it in other antiviral regimens. We saw these with also hepatitis C as well. These drugs inhibit or interfere with the ability of the virus to become fully potent or fully mature, fully capable of infecting a cell. They have high genetic barriers to resistance, so that's good. You find them in a lot of the drug combinations, particularly the older ones. The problem with them is they cause a lot of the metabolic side effects that we'll see with these regimens in patients with AIDS. So if you look under the adverse drug effects, here's where you see it. Insulin resistance, so drug-induced diabetes happens with these drugs. Hyperlipidemia, lipodystrophies, liver toxicity, bleeding disorders. So that's why you've seen the other class kind of supplant this because of these different metabolic effects. If you see patients on protease inhibitors, monitor and look for those other causes. That's mostly the patients I saw in diabetes clinic were on protease inhibitors. So darunavir and atazanavir are in this class. They both require boosters. Okay, so kind of lump them together. They're pretty well tolerated. Severe effects are rare, so the Stevens-Johnson, so the hypersensitivities can occur. Atazanavir is a newer one. It does not have as much trouble with insulin resistance. So if you had somebody who is high risk for developing diabetes, you might think about that protease inhibitor or have discussions with the people who are taking them with regards to that. Disadvantage to atazanavir is that it requires them to eat when they to get best absorption. Okay, so those are the 4 classes. So if I give you a combination product, you should be able to tell me what each of those products, what each of the drugs in that product does. Here's the pharmacologic boost. So the protease inhibitors as well as the integrase inhibitors usually require a boost. Again, we're boosting the trough concentration. So usually we're interfering with the ability of those drugs to be metabolized. So if they can't be metabolized, they stay in the body longer. So we refer to that often as like an area under the curve. So this is the area under the curve, such a novel term. So if you can't metabolize it, it stays higher longer and it stays around longer. So the area of the under the curve goes up. Okay? So we're taking advantage of a pharmacologic effect to get a different pharmacologic effect. Okay? So when we do this, we can dose the drug once a day. Okay? We can keep serum levels higher, keep viral activity low or non-existent. Everybody see? Again, we don't use them for their antiviral effect. Okay. Oh, the other thing I put in there is, so Cmax. So Cmax is the maximum concentration. So here, the Cmax is higher than what it is here. Okay, crude drawing, but maybe keep that as a visual. So that's good, because usually your Cmax is at your maximum activity, so that is where you get your most viral suppression. Usually also it goes with Cmax is highest concentration or time of side effects is what the Cmax usually will tell you about. So the boosters improve under that second bullet. They improve potency. They less frequent dosing, and decreases pill burden. So what do we mean by that when we say pill burden?
Don't take
It's a number of pills. So if you've seen people at Good Shepherd with lots of medications, you think about having to take all those. So if it makes you sick, then you're less likely to take them. Or people just don't want to swallow all those. Or people have difficulty swallowing. Going to one pill is better than 4 pills. They may have difficulty swallowing because they have an esophageal candidiasis. They may have just psychological things about swallowing pills. Some people just cannot swallow a pill. We talked about ritonavir is a protease inhibitor. We're not using it for its metabolic or its viral effect. Let's see, next page. I may have covered most of this. These add very little burden of adverse reactions to the combination. Mostly what they'll add is GI side effect, but they're low. Again, we use low dose. So usually this is not the part that is making them sick. Questions about pharmacokinetic booster. You need to put a big asterisk by it, but I guarantee you I'll ask you about it. It's an important concept. Okay, adherence, really important. The combinations that they have nowadays are very potent. And so once patients they've achieved a viral load that is non-detectable, usually then the regimen is a little bit more forgiving of missing or not being strictly adherent. You never want to tell a patient that, but you can use it to reassure them that, you know, if they missed a day or two, they are not going to become resistant or get sick again. That was not true in the past. People who missed were at high risk of viral loads shooting back up. So our current regimens are better in that regard. But adherence is really important. I cannot drive it home any faster. I can't say it any more often. I see you guys struggle with it at Good Shepherd. So when you come out of the room, you'll tell the people you're talking to about what they're doing, and so if one of us says, are they taking their medicines? Yes, they said they're taking their medicines. I'm telling you, people do not take their medicines as you prescribe. They just don't. So for you to ask is how you ask and how you get that information is important, okay? Because you will make decisions based on that. So I'll give you an example of a student yesterday who patient came in, got lab, didn't look like the drug was working. She went back in, she came out and said, patient says she's taking the drug. She went back in and subsequently, with more explicit questioning, found that, yes, she was taking it, but she was taking about every 1 or maybe 1 to 3 times a week, something along that line, okay? So when you ask a patient, are you taking your meds? They're going to go, yeah, I'm taking them. I'm taking them 1 day, 5 days, 7 days. They are not going to tell you the truth. They're not. They'll over-exaggerate their adherence because they don't want to disappoint you. They don't want you to be angry with them, and they want to do what they want to do, okay? Just because you tell somebody, I'm giving you this medicine, take it every day, but that doesn't necessarily mean they have to take it every day. That's the way people think, okay? So it is medical, it is our arrogance as providers to think that I'm smart, I figured it out, people come to me, I hold their help, I'm being facetious when I'm doing all this. And when I tell them to do something, they will do it. Because I'm authority, I'm whoever I am, they're going to do it. I'm telling you, people will not do it, okay? If you assume and make decisions based on the fact that you think people are taking a drug, you will make a mistake. So what the student did yesterday is she said, I'm thinking about changing this drug dose, but I do not want to do it. I just want to make sure that I understand how you're taking it, because I don't want to make a judgment that will cause you trouble, that will make you sick, that could harm you. Well, then the patient confessed up. No, I'm not taking it every day. Okay? I'm telling you that I see all of you do this at Good Shepherd, and I can't tell you any more that you have got to assess adherence. But I'll tell you, when you go out there, you won't see your preceptors do it either. People are making decisions based on limited information. Now, all of a sudden, physicians have discovered this. So I'm so sorry, but it just irritates me. So now there's these things that are coming out, editorials that are like, dose escalation in the face of medical non-adherence, or medicine non-adherence. Well, that's been going on forever. They just haven't figured it out. I can't tell you how many doctors, when I was in the hospital, would come and they'd say, this patient's toxic on this drug. They did a drug level. But the doctor on the outside says they've never been. They've always been under subtherapeutic. I'm like, well, it's because you're giving them the drug every day. It's always the problem when you put people in the hospital and you give them the drug every day. Their blood pressure falls out. They get hypotensive, their blood sugars go, they get hypoglycemic. I'm telling you, people do not take their drugs, okay? But you're making a decision based on it as they are. So always, always assess adherence, always. I don't know what else I can do. Okay, so it's really important that these folks take their medicine, because if they don't, the virus just takes back off. All we do is suppress them down to 0, but there's always a few out there that are lurking, and they'll just pop right back up. They're masters, master virus. Okay, so strict adherence is most important when initiating or changing a regimen. Most people, when they are newly diagnosed with a major disease, usually are very adherent. So you can use that. But it gets wearisome. This is for life. There's no vacation from it. You can't get away from it. You can't get cured from it. It wears on people. They get depressed. Life changes. Gravity of their situation starts to fall on them. It becomes difficult and hard and burdensome. And so they may take vacations. They may forget. They may lose their home, and so they move on the streets, and then they can't get it. They become homeless. So there's a lot of homeless folks that have HIV. So always assessing that is really important, and that's what I see your role in primary care is do that. I ran into it all the time, was the non-adherence. So if you look under 1, 2, 3, 4, 5, 6, 7, so adherence can be difficult to assess. That is a duh, it is. So one study said that Clinicians incorrectly predicted adherence in 41% of patients. I think that's an underestimate. I think most people do that. Assume that patients don't take it, assume that they exaggerate. I do the very same thing. I take levothyroxine every morning. You're supposed to take it 2 hours before you eat. I never do. I'm not getting up 2 hours before breakfast in order to take that pill. So I'm pretty consistent in how I take it. So I'm hoping that when they test my TSH, it's just all washed out because that's the way I always do it. Now, if my doctor said, do you take your levothyroxine? I'd go, yep, I take it. I rarely miss it. But a couple of weeks ago, I ran out. I didn't get to the pharmacy for 3 days, but I know it's got a long half-life, so I know these things, so listen to what I do. Okay. Talk to patients about how they're going to be adherent. So helping them to link. What do you do every day? The more people will link something to what they have to do, the more likely they'll remember it. Some people do visuals. As long as patients can tell me their approach, I'm usually leave them alone. Some people don't want to do pill boxes. Some people want to line them up in front of them and they take it down and they do their same regimen every day and they put it right back up in a different way. Morning time, most people are pretty good. Nighttime, people are not so good. So talk to them about that. You can always call a pharmacy. You can always pick up the phone and say, can you tell me when they last filled it? How many of you seen me do that at Good Shepherd? I'll call Walmart. When did they last get this? This lady's telling us 3 doses of levothyroxine. Which one is it? Well, we don't have anything since March. Okay. So it tells you. But I'm very careful about how I confront a patient with that. I'll go back in, and I know that's back there, so I use different ways to talk to them. Okay. So tell me, has there been a time when you've run out? Has there been a time when you couldn't get it? Have you ever gotten pills that look differently? Just talk to me about how you are getting your medicines refilled. I'm really concerned because, and I'll tell patients, what you're telling me and what I'm seeing in the lab do not match. I can't reconcile it. Help me. Here's what I understand you're doing, but correct me if I have said it wrong or understood it wrong. I never get right up in their face about it. It would be really rare that I did that. I'd have to know a patient really well. But so I use it as my way to try and figure out every way I can go about it, figure out why you're not taking it. The reason people are taking it is as important as the fact that they're not taking it. So barriers can be money. It could be they just don't believe you. It could be that they don't believe in the medicine. It may be cultural. It may be a stigma. It may be that they just don't want to take medicines. They don't want to be sick. They can't come to grips with the fact that I have an illness. Okay? So those reasons are important to find out. And you may not find out the first time. It may take you multiple visits. It may take you a relationship before they will trust you. Creating an atmosphere that allows people to be honest with you is important. Okay? If you don't seem to be interested in that, if you are harsh or you come across fairly removed from them, they're not going to tell you stuff. Okay? So making it, I just tell them, I'm a pharmacist, I can't remember always take my medicine. Where is it a problem for you? Okay? Open up, use something of your own self that will open it up and allow people to be honest with you. Okay, I put that down at the bottom. I've already said it about the more potent combinations nowadays. So once patients' viral load has gone to non-detectable, they're not as vulnerable as they have been in the past. Don't tell them that unless you need to assure them that this is probably okay. But you should encourage patients if they have missed. Let's say they come in, they're seeing you, they've been sick and throwing up for 3 days, and they tell you, I haven't been able to keep anything down. And you say, does that include your HIV medicines? Yes. You need to call the provider. Because they may need to do another viral load on them. They may need to repeat. They may need to do something different. It may not be your job, but it is your job to tell them you need to get back in with your physician today. Call. Okay? Or you call? Okay, so that was a big soapbox. So, comments or response to that? Anything she told you yesterday that I have told you that's different? Did she talk about adherence? Yeah, it's a big thing.
She listed out the drug, but that's what she wasn't going to go into too much, so she didn't.
Did she talk about adherence?
No.
What did she say? Anything different? Any tricks they have?
Just that it's difficult, but that now the daily drugs have made it a big difference.
Okay, good. Okay, lab monitoring, you probably covered these. I'm just going to hit them. But we're going to talk about the metabolic a little bit more. So viral response is going to be measured in everyone. How quickly their viral count responds depends on the regimen that they're on. If you look at the next page, it gives you a list. Some drugs are very fast. So I put up there at the Integra strand transfer inhibitor-based regimens are, most rapid declines go there. Okay? Look back. What did those drugs do? Why would that be? Well, those drugs, back on page 5. So that's how fast they can get, that's drugs that inhibit the ability of the drug to get into a host cell. So if you can't get in there and you can't produce, then that's why you get those falls. And then you're waiting for those other drugs to destroy what is already out there. Okay? So the second ones, the next ones are the non-nucleoside reverse transcriptase inhibitors, and then the protease inhibitors are the slowest. Okay? So it'll depend on their regimen makeup. Here are some benchmarks that we would like to see. A 10-fold decline in 1 to 2 weeks, a 100-fold decline at 4 weeks, and everybody we want nil at 24 weeks. If they aren't there, then they need a regimen change. They may need a viral assessment to figure out where the resistance has come in. CD4 cell counts. This tells you about the immune status of the patient. So this is a virus that kills off your immune system, right? And then you die of opportunistic disease or weird cancers. Okay, so this tells you, is the immune system holding? Is it healthy? Are they likely to be affected by an opportunistic disease? So that's what the CD4 cell counts are. Other things are, these would be, oh, that should be CBC. CBC. CBC with differential, okay, so these drugs can affect bone marrow. Basic chemistries, mostly kidney, because some of these drugs we would have to alter, or these drugs can cause kidney disease, we've talked about. A U every 12 months, that's almost everybody. ALT, AST, and bilirubin. So these drugs can be affected by liver disease, they can affect liver function. So a baseline, a follow-up once drugs are started, and then periodic the 3 to 6 months thereafter. Okay? It's pretty common with a lot of these major drugs that we have looked at over time. Now, the other ones to keep in mind: higher cardiovascular risk, higher diabetes risk. Okay? Blood pressure tends to be higher in HIV patients versus unaffected patients, regardless. Their lipids tend to be higher, and they end up with more drug-induced diabetes. But if they have co-infections with Hep C, you can see it because of that, because of the increased risk with the Hep C. So these folks need to be monitored for their lipids, lipid management. The HIV clinic at OU, they have their own lipid group within their HIV clinic that manages their patients. You treat them just like you do patients that are not infected. So the same criteria, same risk factors, same drugs, okay? Same goals of treatment are used for them. The difference is the statins are still first choice, but they have lots of side effects. Drug interactions. Remember, 3A4, huge with the statins. So if you're going to use a statin, you really have to look at the drug regimen to see is it compatible, is it one you could use? Probably need to have conversations with the people who are treating them as well for the HIV. For the glucose intolerance and diabetes, again, looking for that at baseline, following up with regular A1Cs and fasting blood sugar checks, especially if you've got them on a protease inhibitor. So diabetes is immune depressing, suppressing anyway. So we really don't want them to have that. We want their diabetes, if it appears to be well treated. We treat them the very same. Goals are the same. Drug use is the same. Yes.
For the lipid levels, would you want to keep them within like a high risk or diabetic range, or just below normal, like in normal range? Because like for LDL less than 70 or less than 100, or
Yeah, it depends on what camp you're in. So so the American Heart Association came out, and the American College of Cardiologists, they have come out with now more, remember, high intensity, moderate intensity, or low intensity, and they are looking at the power of those drugs in those categories and what percent they will lower. So they don't tend to adopt a specific LDL goal, whereas the National Lipid Council does. So they are the ones that are less than 130, less than 100, less than 70. So I think it depends on the patient. You know, what's their risk? What can they tolerate? More drug, more side effect? Good question, Lynn. Questions about those? This section's important, I think, so please pay attention to it. The next one, in considerations prior to initiating treatment, I am not going to test you over. I think it's good to look at it because it raises some issues. One is that you have to look at what is their health status to begin with. Do they already have heart disease? Do they already have liver disease? Do they already have morbid infections, Hep C, Hep B? Do they have tuberculosis? Because that will change the way they are treated. Do they have psychiatric conditions? Because the drugs can exacerbate that. They can also get the infections in the brain that can worsen it. Remember about the testing for abacavir. It's the only one in this group that we do HLA testing. Other factors that affect the regimen themselves: pill burden, number of pills. That's getting better. Financially, psychologically, socially, what are their supports? And very last is PrEP. Did she talk about this? Did you all talk about prophylaxis?
yes, she said she considers it mostly for couples where one is infected and one isn't.
Yes, very good. So this is becoming more popular, so there is a combination. This is the most recent blurb that came out about the using PrEP in men who have sex with men. One partner has doesn't have HIV, but the other is infected. So these are people at very high risk of acquiring an HIV infection. So there's a combination of tenofovir and emtricitabine that can reduce the risk by 90%. On the West Coast, there's a lot of pharmacies who will do the testing and the counseling, and I think Oregon, I don't know if California does, and Washington, pharmacists have the legal ability to see these folks, evaluate them, and start medicine and follow up with them. But other clinics are established to do that as well. So you can come in and be evaluated for risk and then drug be initiated. It is only approved for 18 and older, but I did see some information that looked at 15 to 17-year-olds. The big problem was their adherence. So a very vulnerable population, not very adherent to begin with, and so extra care needs to be taken if you're going to use it in adolescents. Okay, questions? Yes.
I don't know if you have a better idea on this. You were looking at some of the HIV-specific laws and like legislation within the state, because the lecturer was saying she had a patient who had two wives previously who had both died of AIDS and came in with a third wife and wasn't telling the wife about it. And she was saying that like her patient confidentiality kept her from being able to tell the new wife.
Really?
But if the disease is reportable, like, I was just curious, like, how the provider legality of things versus the state laws on transmission and that kind of, like, how you would balance something like that.
You know, I don't know. I know that for some reportable diseases, they will ask for contacts and then they will go after those contacts. But I just don't know, do you?
But even in that case, he has to report that
Right.
person as a contact.
Right.
If he's in denial and he's not reporting his contacts, the health department can do that. But you have the right to do that.
But only the health department does, and like, in our role, it's more important for us to think about our
Yeah, but
patient
it's-
confidentiality than anything. I also was wondering, like, I think she was in private practice, but would it be a reasonable thing to fire a patient for something like that? If they're not, I mean, that's also hard, because then you're not treating a sick person, but.
Well, that opens up a lot of ethical.
Yeah. But it was interesting, so yeah.
I don't know, because I don't deal in that population, so I just can't advise you, I don't know. That would be an interesting thing to hear from people who have to work at that all the time.
She said that when she looked up laws, that her hands were tied for informing the spouse, but I was just, well, we do have HIV specific, like, criminal laws in the state of Oklahoma, so.
There was a guy arrested recently because he was sleeping around with like 4 women and
Yes.
started lots of.
Yeah.
Well, and then, like, in the law, it says there has to be, like, intent to spread the disease.
Right.
But
Yes.
also, like, who would
You're
admit to
married.
that?
If you're married and you're not telling me, that's insane.
Yeah.
Good questions.
Yeah.
Okay, let's look at amphotericin then. Okay, if you'll switch over to your amphotericin B. So have you talked about invasive, systemic, fungal infections? Okay. So what makes them different from a bacterial infection?
They're dimorphic. Eukaryotes.
They're what?
Dimorphic.
Okay, so what's dimorphic mean?
So they're either cysts or spores, or they have the filaments.
So how does that change?
They change their form whenever they're inside the human body.
Okay, so how would that make them different from bacteria in terms of you seeing a person figuring out, do you have bacterial or do you have a fungal? You can't. You can't. It's hard. It's very hard to discriminate between, because a fungal infection will present like a bacterial infection. So they're hard on a clinical plane to discriminate between. Yes.
I think the only definitive way to discriminate between bacterial and fungal infections is through a KOH prep, and so you might do it microscopically.
You could for some things, you can't do it for a bloodborne. So that's another, so you raise another issue. It's hard to draw blood and figure it out from a blood draw. The other, so who gets fungal infections, systemic fungal infections?
Immunocompromised.
Immunocompromised, so you have to have a high suspicion for. So either somebody is immunosuppressed or they've got some type of risk that is putting them at that. People who have indwelling catheters. People who have been in the hospital for a while. Canada is now the 4th cause of nosocomial infections in the United States. So you've got to look for where have you been, what's your health status, to think about that. We also don't have susceptibility testing for the fungi, for the yeast and the molds, like we do for bacteria. So that makes it a little bit different. So the gold standard for treatment of serious, systemic, invasive fungal infections has been amphotericin B. It's been around forever, but it's a very toxic drug. So there have been non-amphotericin B drugs developed, and so they are available for all but the very sickest of patients. But we're going to talk about because it's so toxic and it has its special place in treatment. So what do you all know about amphotericin B? What did you learn? Not much, really?
It's listed a lot.
Okay, page 2. Okay, so these drugs, so all the antifungals bind to a fungus wall. They bind to the ergosterols, and they cause pores to develop in the cell membrane, and then the contents just leak out. It's not pretty, but it works. So this drug is considered to be fungicidal. So that means what?
Kills
It
fungus?
kills them. So it doesn't suppress their activity, it kills them. So it's fungicidal, so very effective. Let's see. Should not be used for non-invasive forms, so thrush, we would use nystatin. Vaginal candidiasis, we use the azoles, the topical azoles. Esophageal candidiasis is pretty common, so we don't use it for that either, because our other azoles will actually work. This is not an azole, it works by a little bit different method. Spectrum of activity is very wide, so it will affect almost all the forms that you are going to come across on a common basis. So Cryptococcus, the Aspergillus, most of the Candida species, the molds, the mucormycosis are all susceptible to amphotericin B. At the bottom of that page, most important, I can guarantee you it will be asked, you have to know the formulations. You have to, because if you don't and you make a mistake, you can kill somebody. So the traditional, conventional amphotericin is the amphotericin B deoxycholate. Okay, that's the oldest one. That's the one that causes a lot of the renal toxicity. And because it was so toxic, they developed these other forms, 3 of them, now 2 of them are still on the market, are lipid emulsions that are used to deliver the amphotericin. So there's amphotericin B lipid complex, that's an Ablicet, and liposomal amphotericin B ambisome. You have to know those. Okay. The lipid emulsions are not interchangeable with the amphotericin B. They are dosed differently, and you cannot interchange them. Now, the 2 emulsions are not the same, but people consider them interchangeable. Okay? So let's say you wanted one, but the other's on the formulary, that'll work in terms of the lipid. But you don't want to mix up the lipid and the conventional, mostly from a dosing standpoint. Okay, next page. So let's talk about the conventional one. Standard of care for a long period of time, not absorbed orally, so we have to give it IV. Look at the terminal half-life, 15 days. So if we dose them for 3 to 5 days, how long is that drug going to hang around? A long time. So that's why the fungicidal activity of that drug continues way past when you stop giving it. So you also must know the doses, because I want you to keep in mind that they are different, because that's where the big mistakes have been made. So the daily dose of the amphotericin B deoxycholate is 0.5 to 1.5 milligrams per kilo per day. Usually those high doses above 1 milligram per kilo per day are for the most sick, the most severe. Okay, so most of the time it's going to be that 0.5 to 1 milligram per kilo per day. Don't exceed the 1.5 milligram per kilo per day. That leads to a lot of renal toxicity. Okay, most of the time this drug is given IV, but it has been given by multiple routes. So I want to just tell you about them. I'm not going to test you over them, but you should know that people have done this. I don't practice in the hospital anymore, so I don't know. But when I was a resident and young faculty member, we used every one of these routes. So the IV is the one you're going to deal with the most common. Infusion time is important. Less than 4 hours, you tend to get a lot of infusion reactions. So dosing it over a 4 to 6 hour period of time is important. So longer infusion time, usually less side effects. Pre-medicating them, so using Tylenol, hydrocortisone, diphenhydramine is used to decrease infusion reactions, and I've got that written down on the next page. We used to use, and I would imagine they still do this to some extent, is we did a lot of bladder installations of amphotericin B when people would get candidiasis in their bladder. So if the dose was you put 50 milligrams in a liter of saline and you infuse it in and then you pull it back out. It's not really recommended for routine use anymore, but that was a very common use in the past. Intraperitoneal, they'd infuse it in and they'd suck it out, but it causes lots of aggravation and abdominal pain. So now they recommend that what you do, don't do that, take the catheter out, treat them systemically. So getting rid of the risk factors for candidal infections is preferred. Intrathecal, so cryptococcal meningitis, this is the drug of choice. And we still use the conventional one over the lipids. So we would instill them intrathecally, put them right into the spinal fluid. But it's very irritating, can cause arachnoiditis. And so it's really, if we can not use it, we would prefer not to. So vomiting, headache, back, leg pain, loss of bowel and bladder control, nerve palsies associated with that. The last is to aerosolize it. If somebody has got a fungal infection in their lungs and we're not getting an adequate effect, or we want to boost what we're getting from systemic, people have used it by inhalation to treat, to prevent in people who are at higher risk for opportunistic disease like malignancies or a lung transplant folks. Questions about those? Okay. Let's look at adverse effects. These are important. So infusion-related reactions are common. Again, the pre-treatment, those are listed there for you. Nausea is also common. So using your common products like promethazine or prochlorperazine, ondansetron, can be used to prevent or treat nausea due to the infusion reaction. Phlebitis. So lots of drugs that we put in the veins are very irritating, and so we'll get an inflammation. And they're very painful, and they last a long time. So to decrease that, we can put the amphotericin through a central line in the neck, or we can alternate infusion sites each time we give it, or lower the concentration, slow the infusion time down. Drug-induced fevers are also common with amphotericin B infusion, so using Tylenol is reasonable, diphenhydramine. Non-steroidals have been used as well. Nephrotoxicity, very, very common. The last part of the handout is just over nephrotoxicity. The good thing is it's reversible. Usually if you catch it, and you should be monitoring their serum creatinines every day. Usually it doesn't go above 2.5. The patient's kidneys usually will come back to normal. The risk factors there you should know though. If you use it, the more commonly times it will occur is when you use it with other nephrotoxins. So aminoglycosides would be a common drug that you would find them also receiving. Cyclosporin if they're a transplant patient. Cancer chemotherapy, a lot of them are hard on the kidneys. Oscarnet is a antiviral agent, so any of those, keep that in mind, that's important. The amphotericin B deoxycholate is the worst of the three in causing nephrotoxicity. The liposomal amphotericin B is the least. So you can, and for the most part, the lipid emulsions have supplanted the use of the conventional product in most cases. Because there's destruction or there is injury done to the distal tubule, these patients tend to lose potassium and magnesium. So monitoring for that and replacing. It's hard to get their potassium replaced if you don't also do the magnesium. So monitoring for their electrolyte losses. Next page, patient monitoring. Just a few things to say about that. So infusion reactions, anytime that you are infusing a drug, you're going to, the staff is going to be looking at how the veins are holding up. Measuring their renal function, so daily while they're on it. Assessing there's those potassium and magnesium, and also CBC. This drug can cause anemia and also leukopenia. So looking at white and red blood cell counts is also important. Okay, this is just a little bit on those lipid-based ones. Those two are listed there. The dose is different. I want you to know the dose so that you can keep it in mind. Here the dose is 3 to 6 milligrams per kilo per day. So it's about 3 to 5 times what the conventional. So that's where the deaths have occurred, is when people use that dose for the conventional amphotericin. In terms of adverse reactions, they're pretty much the same. You just see less with the lipid-based compared to the conventional. Except that the liposomal amphotericin B has a different type of infusion reaction. If you look down there, it's mostly cardiac and respiratory. Chest pain, dyspnea, hypoxia, abdominal pain, flushing, and urticaria. Much worse than what we see with amphotericin B deoxycholate. Here, a pre-treatment with diphenhydramine or Benadryl will usually protect that. You see the same electrolyte abnormalities, so potassium and magnesium. Questions about those? Okay, we're just about done. So amphotericin nephrotoxicity, this is the important part, this is why we're talking about the drug. It's very common. It impairs the renal function. Reversible serum creatinine is what tells you that the problem is going on. But you can see other renal complications listed there. So you can see a renal tubular acidosis. You can see a nephrogenic diabetes insipidus also occur. The amphotericin B causes renal vasoconstriction, so it decreases the output or the filtering through the glomerulus, and GFR goes up. Again, those risk factors are listed there for you. Nephrotoxins, important. Chronic kidney disease, if they already have an insult to the kidney, then they're more likely to react to the amphotericin, and it's dose dependent. So remember, I told you if you use the lipid, you'll kill off their kidneys, the patient dies. Pathogenesis is the vasoconstriction and also tubular, mostly distal tubule injury. They think that the deoxycholate is a detergent. It's put in there actually to make the amphotericin be more soluble. They think that that is probably a huge contributor to the nephrotoxicity. So that's why the lipid ones probably don't cause as much. So in terms of prevention, use lower doses if you can. Avoid other nephrotoxins. Salt loading. So they have found, because of the injury to the distal tubule, if you can keep up the salt load, because they can't conserve their sodium as well anymore, we salt load before we give it and after. So you give an infusion of normal saline, which would be what? What's normal saline? It's sodium chloride. What's the percent? 0.9%. You should know that. Okay, so when people say normal saline, they mean it's isotonic, it's normal tonic with the blood, so it's a 0.9%. That'll probably come up a lot more when we're in ER next module. So saline infusion, know that one as well. Know that the lipid-based are less likely to cause it, and they are usually the ones that are used at this point. The only place where that I read where the conventional is used is in cryptococcal meningitis. Usually reversible, If you have to start the drug back, the toxicity will continue, but most of the time, patients will revert back to normal or baseline. Questions about amphotericin B? All right. I will see you next week. We're going to talk about acute treatment of asthma. Good luck on your test.